Good morning. Happy Sunday. For those of you who celebrate, happy Palm Sunday. Happy Passover week for those who celebrate Passover. Thanks for taking the time to be with us today. We want to give you an update as to where we are. The number of cases increase, which is nothing new. It's happened every day since we've started this. It's been a long month. Something a little bit different than the data today. We're not really 100% sure yet what the significance is as we're feeling our way through this. Number of people tested, 18,000. Positive cases are up 8,000, total of 122,000 cases. Number of patients discharged, total discharged up is 12,000, 1,700 discharged in one day. Number of deaths is up. That's the bad news. It's 44,159. And we pray for each and every one of them and their families. And that is up, and that is the worst news. But the number of deaths over the past few days has been dropping for the first time. What is the significance of that? It's too early to tell. This is the impact by state. But as I said, the interesting blip maybe in the data, or hopeful beginning of a shift in the data and the number of cases. Total number of new hospitalizations is 574, which is obviously much lower than previous numbers. That's partially a function of more people being discharged. But you see ICU admissions are also down. The daily intubations down slightly from where it was. Again, you can't do this day to day. You have to look at 3 or 4 days to see a pattern. Discharge rate is way up, and that's great news. And the statewide balance of cases has been relatively stable for the past few days. There is a shift to Long Island. Upstate New York is basically flat. And as Long Island grows, the percentage of cases in New York City has reduced. This is when, for those people who look at the data, you have all these projection models, and what's been infuriating to me is the models are so different that it's very hard to plan when these models shift all the time. But there's also a difference of opinion on what happens at the apex, right? Everybody, all the models say you go up until you go down. Thank you very much. Then there's a difference of, is the apex a point or is the apex a plateau? In other words, do you go up, hit the high, and then immediately drop, or do you go up and then there's a plateau where the number of cases stays high for a period of time and then drops? There's a difference of opinion. So you have to think of that when you think about what you're seeing in the numbers, because you could argue that you're seeing a slight plateauing in the data, which obviously would be good news because it means you plateau for a period of time and then you start to come down. And we're all feeling our way through this. And we have the best minds in the country, literally on the globe, advising us, because New York is the first. I also think it'll be very helpful for the other states that follow. I was just talking to Dr. Zucker about codifying everything we're learning, because when the next states start to go through this, we hope that they can benefit from what we're going through. But we're looking at this seriously now, because by the data, we could be either very near the apex, or the apex could be a plateau, and we could be on that plateau right now. We won't know until you see the next few days. Does it go up? Does it go down? But that's what the statisticians will tell you today. As we've said before, the coronavirus is truly vicious and effective at what the virus does. It's an effective killer. People who are very vulnerable must stay isolated and protected. I mean, that was the point from day one. That was the point with Matilda's law, my mother. You have to isolate and protect those people. If a very vulnerable person gets infected with this virus, the probability of a quote-unquote cure is very low. And that's what this has really been about from day one. That small percentage of the population that's very vulnerable. Major effort that has impacted everyone to save the lives of those people who are in the very vulnerable population. If you're not in a part of that vulnerable population, then you will get sick. 20% require hospitalization, but the hospital system is very effective and it makes a real difference. And that's why the highest number of people ever now being discharged, right? So you're just seeing the evolution of this whole story. You're seeing the narrative unfold, right? We're all watching a movie. We're waiting to see what the next scene is. And as the movie unfolds, you start to understand the story better and better. Rush of infection rate, rush of people into the hospital system. Hospital system capacity explodes. More people are in, but more people are coming out. 75% of those people who have now gone into the hospital system are coming out of the hospital system. It also helps with the capacity of the hospital system because obviously the more people who are coming out, it makes it easier to handle the large influx that's coming in. Having said all of that, the operational challenge for the healthcare system is impossible because the system is over capacity all across the board. It's just over capacity. So what we're basically saying to a system is you have to manage with the same resources that you have, same staff, an overcapacity situation. And that is putting a tremendous amount of stress on the healthcare system. You're asking a system to do more than it has ever done before, more than it was designed to do with less. I understand that, and I get that. And day in and day out, the commissioner and everyone at this table deals with the healthcare system. I understand what they're dealing with. I understand they're being asked to do the impossible. And they are being asked to do the impossible. But life is options, and we don't have any other options. So you get to a situation and you do what you have to do in that situation. And that's where we are. The only operational plan that can work, right? Because you know the system doesn't have the capacity, doesn't have the supplies, doesn't have the staff. So how do you handle this surge over capacity? We have to surge and flex, which means you have to deal with, if you're an individual hospital or hospital network, yes, you're going to be over capacity. And the only way we can make this work is if we flex the system so that we take all hospitals, all hospital networks, some hospitals are in networks, and we work together as one system, which has never been done, right? We have public hospitals, we have private hospitals, we have Long Island hospitals, we have New York City hospitals. In totality, it's the healthcare system. The state manages, regulates the healthcare system, but they're all individual hospitals or individual networks, and they are accustomed to just doing business and managing their own affairs. That doesn't work. We have to balance the patient load among all of these hospitals. So if one hospital starts to get high or has a projected high intake, we have to shift that patient load to other hospitals. That means some patients who show up at their neighborhood hospital may be asked, can we transport you to another hospital, which is not in your neighborhood, but actually has more capacity. So we have to adjust that patient load among all of the hospitals, which is a daily exercise, and it's very, very difficult. We're running short on supplies all across the board. Some hospitals happen to have a greater supply of one thing or another. One hospital has a greater supply of masks, one hospital has a greater supply of gowns, and when we're talking about supply, hospitals are accustomed to dealing with 60-day supply, 90-day supply. We're talking about 2 or 3 or 4 day supply, which makes the entire hospital system uncomfortable, which I also understand, because we're literally going day to day with our supplies, with our staff, et cetera, which is counterintuitive and counter-operational for the entire healthcare system. And I understand that also. The big operational shift will be that Javits coming online. If we get that up and running efficiently, that's 2,500 beds for people who test positive with the COVID virus. That is a major shift for the systems. And at a time when we desperately need a relief valve for the system, Javits could do that. So we're working very hard to get that up and running. But that rolling deployment, that flexibility, there is no other way to do that, to do this on the state level. You know, I can't say to a hospital, I will send you all the supplies you need. I will send you all the ventilators you need. We don't have them. We don't have them. It's not an exercise. It's not a drill. It's just a statement of reality. You're going to have to shift and deploy resources to different locations based on the need of that location. I think that's going to be true for the country. The federal government, everyone says the federal stockpile, federal stockpile. There's not enough in the federal stockpile to take care of New York and Illinois and Texas and Florida and California. It's not an option. The only option I see is there's a national deployment. Everybody says this is wartime. It is a war, and the virus is the enemy, where New York, help New York today. Thank you, State of Oregon. We're dealing with this curve today and this intensity, and then nationally, we shift the resources to the next place that is most impacted, right? Just what we're doing in New York City, in New York State on a microcosm, we shift resources from the Bronx to Brooklyn to Queens to Nassau, shift national resources and state resources from New York to Florida to Illinois, whatever is next on the curve. We're going to do that in any event. We get through this. People have been so beautiful to us, and it is the New York way. We're going to codify everything we've learned, and we get past this curve. Whatever part of the country goes next, we will be there with equipment and personnel and however we can help. Federal government is also deploying approximately 1,000 personnel to New York. That's doctors, that's nurses, it's respiratory technicians. The immediate priority is to deploy those people to help the New York City public hospitals. The New York City public hospital system, H&H, was a system that was under stress to begin with, before any of this. So obviously, you add more stress to institutions that were under stress. It only makes the situation more difficult. So we're going to deploy all the federal personnel who are coming in today, 325, to the New York City public hospital system. I talk to the hospital administrators on a daily basis. We get them on a conference call, and we do this shifting of supplies and balancing of patient load. I know that I'm asking them to do really difficult things. I get it. I don't enjoy being in this situation. I don't enjoy putting them in this position. I know their staff is all overburdened, but all I can say is thank you. to the administration of this healthcare system, and most importantly, thank you to the frontline workers. I mean, these people, they are true heroes in the truest sense of the word, what they do day in and day out under very difficult circumstances, and we thank them all. On a different, somewhat lighter note, there's an accompanying affliction to the coronavirus that we talked about early on. It is cabin fever. It is a real situation, not medically diagnosed. I asked Dr. Zucker, there's no medical definition for cabin fever, but I believe it exists. It's a feeling of isolation. It's often accompanied by radical mood swings, resentment of people around you, varying degrees, for no reason whatsoever, just an upwelling of resentment, especially towards people who are in apparent positions of authority in the situation, which I've noticed. Irrational outbursts can come in at any time without any warning, just an irrational outburst, frustration, anger, with no rational basis. Cabin fever, in many ways, also threatens the essence of our Constitution, which is premised on people ensuring domestic tranquility, and it can be disruptive to tranquility. I can attest to that. It's a real thing. Think about it. It's only been 1 month, but it's been a long month. Positive interventions for cabin fever. I'm going to take up running again. I used to run back normal days before this job, but I'm going to start running again. My daughter Cara, we're going to run as a family. We're going to go out there. Cara's got a head start. She's out there doing 5 miles every day. She thinks she can beat me. Give me a couple of weeks. I'm going to be right there, fast like lightning. We're going to do it. We're going to make the dog come. The dog is also experiencing cabin fever. He's a little disrupted. The order of the pack has changed. Different people. He doesn't know where he fits. He has anxiety. He's going to come out. He's going to run. Think of ways to deal with it. I don't have any great answer. But a little perspective on the whole situation is also important. I challenged my daughters. This is terrible. This is terrible. This is terrible. This is terrible. I've been saying it's terrible. It's been terrible for society, the economy, personally. But you know, let's look back at history, right? Generations have gone through terrible times. So my challenge to them is, you find me a generation that has had a better overall situation than where we are right now. Go back, World War I, World War II, Vietnam, 1918 flu pandemic. You find me a generation that hasn't had a challenge to deal with. And we're going to have that discussion. And also keep in mind on perspective, this is going to be over. You see on this story developing, you can start to see how the story ends, right? They will have a vaccine. Will it be 12 months or 14 months or 18 months? There are a number of treatments that are being expedited and are being tested right now. Dr. Zucker in New York is working expeditiously and cooperatively with the FDA to try all new different treatments. The convalescent plasma receptor antibody treatment we're working on, the hydroxychloroquine we're working on aggressively. So we're trying all these new treatments. Some of them show real promise, but you can see that where the story ends. I think, and this is opinion, not fact, I think you see the return to normalcy when we have an approved rapid testing program that can be brought to scale. We're now testing rapid testing programs. But when you get to the point where you can do rapid testing of scale and people can start to go back to work because they know they're negative. We continue to protect the vulnerable population, which is where this was about, but we liberate, as my daughters would say, they're seeking liberation. We liberate people who can go back to work because we know that they're not in a vulnerable category and they're negative. And I think that is It's under development now, the rapid testing, and we're part of it. But that is going to be the answer, I believe. And we get through it because we are New York State tough. Thank you.